Dear ESTS members and webinar attendees, my name is Lieven de Piepere. I'm your moderator for today. This webinar is the fourth one of the fourth season of ESTS educational webinars. The subject of today is Oncology update for thoracic surgeons. As shown by a new massive subscription of more than 550 registrants, this will again be a fantastic journey led by a true expert in the field. I'm very glad to introduce you to a respiratory oncologist with a true gift for teaching and presenting difficult things in the most easy way to understand. Really something for us surgeons. Professor Johan Vansteenkiste is Professor of Internal Medicine at the Faculty of Medicine at the Catholic University Leuven in Belgium. He is head of clinic at the Respiratory Oncology Unit and its Clinical Trial Center at the Leuven University Hospitals. He is also a member of the ESMO Lung Educational Group and Guidelines Group, and he's the associate editor at the Annals of Oncology. Not to forget that he received the 2021 ESMO IASLC Heine Hansen Award for outstanding contributions to education and research in lung cancer. So, as I told you before, he is our ideal guest speaker for today. We will ask your interactivity, so be ready to answer some poll questions, and please ask as many questions to the expert as you want after his presentation. Professor Vansteenkiste, the stage is yours.
Thank you. So, dear colleagues, it's my pleasure to be invited and introduced by Lieven here for this ESTS webinar. And I will try to get to my slides now. Okay. So it's okay with the slides
perfect,
now?
Yes.
Okay. So it's an oncology update for you, thoracic surgeons, and from my piece of the work, I will talk about incorporating new systemic therapies into potentially resectable non-small cell lung cancer. So these are my disclosures. And as Lieven said, we will start with a few questions here. And it's a question about outcome in surgical non-small cell lung cancer patients. And it's a question about disease-free survival and overall survival. So for those of you who may be a little bit less familiar with clinical trial medicine, so DFS stands for disease-free survival, which is the time from surgery to relapse or death, whichever comes first. And overall survival is the time from surgery to death of any cause. And so in an average patient, of course, DFS will come first and then OS will come later. And so the question is on adjuvant or neoadjuvant chemotherapy in completely resected stage 2 and 3A. Chemotherapy gives better disease-free survival, better overall survival, and is well tolerated. Better disease-free survival, better overall survival, but may have dangerous side effects. Better disease-free survival, but uncertain about overall survival and well tolerated. Better disease-free survival, uncertain about overall survival, and may have dangerous side effects. So this is the first question. Please have your vote.
So you can vote in the poll sections at the right sidebar, as we normally do. And I hope that this is already being done. Yes, already some people have been voting for this question. And I would like to encourage you to vote. It's anonymous. I know that we are with more than 150 people live and still people logging in, but I still have less than 100 votes. So please do so. You cannot do anything wrong. It's interesting to know for us and also for yourself to learn something. Do we wait for this vote, Professor Vansteenkiste?
Yes, well,
Okay.
I see it's changing a little bit, but actually, it's quite a lot of difference. I mean, all questions have 20% or more. Indeed. So there is a reason to do this seminar, I think. So it's very well distributed across the answers. So this is another question. It's the same question, I mean, it's the same answers, but this is now for immunotherapy in completely resected 2 and 3A non-small cell lung cancer.
So again, you can vote in the right sidebar. For the people who try to vote in the questions bar, that's not the idea. You need to go to the polls section, and there you can vote. Otherwise, I have to count them myself. That's a bit more difficult.
Okay. Well, here on top is number 1. And at the very bottom is number 4. Okay. So next question is the same answers again about targeted therapy. And of course, there is a target then. And I take the target EGFR mutation here. Similar answers. Okay, so on top here is number 1, and again at the bottom are number 3 and 4. And perhaps we could close here.
Okay.
Okay. So this will be the flow. I will first look at how immuno and targeted therapy has changed metastatic non-small cell lung cancer. And I must say the voting thoracic surgeons here are very enthusiastic about what is happening, perhaps a bit over-enthusiastic. So I will try to put things in perspective. And so what is the topic? What are we talking about? Then what is our current standard? And then looking at immunotherapy in the adjuvant and neoadjuvant setting, targeted therapy, and have a summary and clinical relevance discussion. So in metastatic non-small cell lung cancer, this study, Keynote 024, compared chemotherapy to immunotherapy in patients with metastatic non-small cell lung cancer and a tumor with high expression of PD-L1. And this is long-term, this is mature 5-year survival. And the 5-year survival of the patients that started with immunotherapy and then usually crossed over to chemotherapy is 32%. For the others, it is 16%. But 32% is really unprecedented in metastatic patients, 1/3 of the patients alive at 5 years. And if you compare this to chemotherapy, on the left side, you see a chemotherapy study of different regimens from the past. And you see the x-axis actually stops at 30 months because there's little to report from then onwards. And if you put this in perspective on the right side with the same x-axis, the same time axis, you see the chemotherapy study on the top and the immunotherapy at the bottom, and you see what a dramatic difference it has made. And the same is true for targeted therapies. So of course, we want to see how we can move this into the surgical setting. And that's a process that really is in development now. So what is the topic here? Well, it's early stage, non-small cell lung cancer perhaps, but it's not so simple. The simple answer I give it to my students: early stage is 1 and 2, locally advanced is intermediate stage 3, and advanced is stage 4. But in real life, it's not so simple, because with each revision in the TNM, there is a shift in categories that are part of a certain stage. Moreover, the therapeutic approach is not only determined by stage, but clearly co-determinant in our multidisciplinary tumor boards by the potential for complete resection. And so the adjuvant immuno studies I will be talking about were done in TNM7 and were labeled stage 1B, tumor more than 4 centimeters, 2 and 3A. And this is the first thing. If you look what happened from TNM7 to TNM8, and this is where we are now, you see that at the one end, look at the green boxes, the tumors more than 4 centimeters moved from stage 1B to 2A. While there was an important change for this topic in stage 3 as well. Formerly, it was stage 3A and 3B. Now it is stage 3A, 3B, and 3C. And so the patients that were in the trials with 3A, some of them nowadays are 3B stage N2 on the right side, the green box on the right side. It's not 3B due to N3, that remains excluded, but there are some shifts on both sides of the curve, on the curve. So what we currently doing is actually in TNM8 looking for stage 2 and 3B defined by N2 disease. And the next thing, of course, we're looking at potentially resectable patients. So we are looking at the ones that are in the red box here with a potential for a complete resection. And so we need to see this trial nowadays in TNM8, stage 2, 3B, defined by N2, and potentially resectable. This is the population we are talking about. And I don't know what will happen in a few years, because in a few years we will have TNM9 and maybe yet another situation.
Can I just ask you to hide this this box because the conclusion of your slide was more,
yeah, okay. So what is our current standard? Well, it's an important field. If you look at numbers and proportions, we're talking here about 450,000 patients with, according to the ISLC database, a 5-year survival between 90 and 41%. So there is something to improve. We know it's probably not with adjuvant radiotherapy, as it's often a distant problem. And a recent lung art study looking at postoperative radiotherapy in N2 non-small cell lung cancer did not show benefit of postoperative radiotherapy in general. So effective systemic therapies would help to save many lives. And going back to the basics, what is the aim of adjuvant or neoadjuvant chemotherapy or therapy in general? It's to eliminate minimal residual disease in order to improve cure rates, and a good proxy there is 5-year overall survival, and this with an acceptable safety profile. And the last is important as well, because in this setting, a curative setting, the threshold for acceptance of side effects is different from stage 4 disease. And we need to realize that, for instance, in the chemotherapy trial, the dose reduction guidelines we had for chemotherapy were more strict in adjuvant trials than they were in stage 4 trials. So is chemotherapy able to eliminate minimal residual disease? Well, it's cytotoxic. So the theoretical answer is yes, but here we have the practical answer as well. From 2004 with the YAL trial, where there was an improvement with adjuvant platinum-based chemotherapy, moderate, but later evidence with meta-analysis and different trials pointed at a stage dependency, but for stage 2, it's a plus 12% for 5 years. For stage 3, it's a plus 15% at 5 years. So it's a part of improved cure rates and proven evidence. Let's look at immunotherapy now. Again, going back to these basics in my yellow box, is immunotherapy able to eliminate minimal residual disease? Probably yes, because what happens in cancer is that, if you look on the left side of the slide, the interaction between PD-1 and PD-L1 paralyzes the immune system so that the tumor has a chance to grow and that the immune system fails to control. What happens with immunotherapy with checkpoint inhibitors is that this PD-L1, PD-1 interaction is no longer there. So the cytotoxic immune cells are able to act on the tumor. And these cytotoxic CD8 cells indeed have the possibility to kill cancer cells, so to eliminate minimal residual disease, at least in theory. And perhaps the data from metastatic non-small cell lung cancer, you see them on the right side here, give us good hope, because in metastatic patients, at 4 years, 5 years, we see a certain plateau in the curve, which means that maybe even in metastatic patients, there will be some possible cures with immunotherapy. So why not in the surgical setting? And then there is the issue of the timing, neoadjuvant or adjuvant. The advantages, both have advantages and disadvantages. The advantages of the adjuvant strategy is you don't delay or miss surgery. You have a full pathological TNM, and you have a large amount of tissue for biomarkers. The other hand, the advantages of neoadjuvant strategies are you have an earlier action on micrometastasis. It's better tolerated in general, better drug delivery as the blood vessels are intact, and you have the possibility to assess the patient benefit with a scan before and after. And in clinical trial medicine, you have the early interpretation of strategy benefits, usually by looking at pathological responses in resection specimens. Moreover, in terms of immunotherapy, there are two additional things that may be important. There is earlier immune priming, and because the lymph nodes are still intact, maybe the immune response is better preserved than when you give the immunotherapy after surgery. But that is, of course, that is all hypothetical. What we know from preclinical data, and this is a very nice study of triple-negative breast cancer implanted in mice. And on the right side of the slide, you see the schedule, simplified schedule. Going from day 1, therapy starts at day 17. And in one group at the bottom, therapy is surgery followed by 2 times adjuvant immunotherapy or a control immunoglobulin. The other part is starting on day 17 with neoadjuvant immunotherapy or control immunoglobulin, and then going to surgery. And so there were a lot of results of this trial, but perhaps the most important one is this. In comparison to adjuvant, the animals with neoadjuvant immunotherapy had better animal survival. If you look on the left side here, just with anti-PD-1 antibodies, you see that the animals that had adjuvant immunotherapy, triangles, did better than the controls, control immunoglobulin, which are in circles, but that the neoadjuvant immunotherapy in squares even did better. And if you give combined immunotherapy, which is on the right side of the slide, these differences are even more pronounced. So this is preclinical, this is mice. Let's look at patients now. Well, in the adjuvant setting, as I said, there are no intermediate endpoints. So you need the full randomized controlled trials to say something. And these trials have been done. Some of the results are available, and a lot are coming available this year as well. It's complete resection 1B, 2, and 3A, good performance status, and patients could have adjuvant chemotherapy if indicated. And there are 4 trials with 4 agents, atezolizumab, pembrolizumab, durvalumab, and nivolumab. They all have a similar design, except some are with observations, others are placebo-controlled, which is, of course, a somewhat better level of evidence. And then they slightly different in size, they're different in endpoints, but otherwise they are rather similar. And so we have data from one of these studies, IMPOWER 010 now. And what is noteworthy in that study is that all the patients that were included had adjuvant chemotherapy, meaning they were, of course, the more fit cohort, because after surgery, as you know, not every patient is able to have chemotherapy, even if it's indicated. So if you have a trial with patients with adjuvant chemotherapy only, then you have the more fitter cohort of your post-surgical patients. But anyway, so this trial, after complete resection and adjuvant chemotherapy, and then these were 1,280 patients who had adjuvant chemotherapy, and of these, there was a random assignment of twice almost 500 patients with atezolizumab for 1 year or standard follow-up. No crossover allowed within the trial. And the primary endpoint was disease-free survival. The median follow-up for this presentation was 32.8 months, so that is quite reasonable. And it's important to understand how the trial was built in terms of primary endpoint. There was a hierarchy in endpoints. And so first in hierarchy was the disease-free survival in PD-L1 positive patients with completely resected stage 2 and 3A. If that was positive, the next level was DFS in all 2 and 3A patients, irrespective of PD-L1. And if that was positive, then disease-free survival in all stages, 1B up to 3A. And so the first level was reported, and this is the curve of the first level, stage 2 and 3A, PD-L1 expressing tumors. And you see disease-free survival hazard ratio 0.66, clearly significant. And if you look, there is a clear spread of the curve, so also clinically relevant. If you look at the 3 levels in the hierarchy, the one that I just showed is the one on the left side here. If you look in the middle at stage 2 and 3A together, irrespective of PD-L1, you see an already different hazard ratio, 0.79, still significant, but the curves are closer together. If you look at all stages, irrespective of PD-L1, it's no longer significant. You may think because of the confidence limits, but according to the trial design, this was not enough to be significant, and you see the curves are quite close to one another. So this is what we have at the present time. I think overall survival is not available yet or reliable yet. What in terms of safety? Well, in terms of safety, we know immunotherapy is in general well tolerated, a gentle therapy. And that's the case, that's true in at least 85% of the patients. But there can be some major side effects, and we should not forget that. And so in this trial, the grade 3-4 adverse events that were treatment related were seen in about 11% of the patients, and in 4 patients, this was a fatal event. Moreover, the immune-mediated adverse events that needed the use of high-dose systemic corticosteroids were seen in 12% of the patients. And then another important analysis was brought at the ESMO meeting last year, looking at the role of PD-L1 in stage 2 and 3A. And so if the PD-L1 is absent, then you are on the equivalent line. If the PD-L1 is present, then you are the hazard ratio of 0.66. But if you look in more detail, nearly all of that benefit is generated by the group of patients with a high PD-L1 expression, more than 50%, hazard ratio 0.43, while the ones with intermediate PD-L1 between 1 and 49%, are on the equivalence line with a hazard ratio of 0.87. Neoadjuvant. Well, as I said, there you have some intermediate endpoints. So you can do phase 2 non-randomized trials. And of course, the number of trials of that kind is exploding. And I won't show them all. I will just show the experience of the Swiss SAKK group, because they have a large experience in surgical multimodality trials since many years. And in that experience, they know that when you give preoperative chemotherapy followed by resection and radiotherapy in case of incomplete resection, their event-free survival primary endpoint at 12 months was 48% historically. And here they wanted, with adding immunotherapy, they wanted to improve this to at least 65%. And so what they did is, in patients with N2 disease, so this is also stage 3A and 2, they gave their standard chemotherapy, then they gave 2 cycles of immunotherapy, then surgery with RT only in case of incomplete resection borders, and then immunotherapy up to 1 year. And so this is what they found. First, the 1 year event-free survival rate was 73%, so the primary endpoint was clearly met. And the data are mature to say this because the median follow-up is more than 28 months. Moreover, because of the sequential design, not chemo and immuno together, but chemo first and then immuno, and there are not so many studies doing this, but it's interesting to see here that the response rate on imaging was 43% after chemotherapy and 58% after durvalumab. So the immuno seems to add something in addition to the chemotherapy. Moreover, and perhaps even more important, 82% of the patients had surgical resection, which is quite nice in the 3A and 2 population, certainly as there were quite some patients with important N2 disease in that study. 93% was an R0, a complete resection. And the major pathological response, this is talking about the intermediate endpoints, major pathological response means less than 10% viable tumor in the resection specimen, or PCR, pathological complete response, no viable tumor cells in the resection specimen. These values were 62 and 18%, which is clearly better than what we know from historical studies. And in this data set, this was independent of PD-L1 expression in the tumor. And then, of course, here as well, we have different randomized phase 3 studies. They are in somewhat higher stages, stage 2 and selected 3B and 2 in TNM7. Patients fit for surgery. And I draw a line here because the trials above the line are trials where after the surgery, there was no placebo control. There was standard of care. Moreover, in the Checkmate 816 trial, and this is the one where we have results because it's the earliest one, it's a bit different as stage 1B was allowed there. And there were only 3 cycles of chemotherapy or chemoimmunotherapy, and there was no continuation of immunotherapy after surgery, which is a design that is presently no longer present because all the trials below the black line are now randomized between chemoimmunotherapy versus chemotherapy plus placebo, and there is always immunotherapy up to 1 year after surgery. Again, different numbers, different endpoints. And so we have some data, early data from Checkmate 816. And in that study, patients with resectable 1B up to 3A non-small cell lung cancer without driver mutations were randomly assigned to 3 cycles of chemoimmunotherapy or 3 cycles of platinum doublet only. Initially, there was also an arm with immunotherapy only, but that arm has been dropped very early in the study. The primary endpoint was pathological complete response, so no viable tumor cells in the resection specimen, but the study is co-powered to look at event-free survival. And what we have now is pathological complete response, and you see it over here. What the first primary endpoint, clearly different, 24% for the chemoimmuno, 2% for the chemotherapy only. And in this data set, this was PD-L1 dependent. It was clearly higher, the pathological complete response rate in PD-L1 positive versus PD-L1 negative patients. In terms of tolerability, safety, it was reasonably good. Not much different in side effects between the 2 arms, chemotherapy or chemoimmunotherapy. But what is a bit disturbing for me in such a study is that when you look at the flow of the study in a separate presentation by Dr. Spicer at the ASCO meeting, you see that in stage 1B or 2, and these are the patients that we discuss at our multidisciplinary tumor board, together with the thoracic surgeons. A few weeks later, they go to the thoracic surgeons, and they usually have a complete resection. Here in this trial, 15% of these patients never made it to surgery. And I don't know how you feel about this as thoracic surgeon, but even for me as an oncologist, this is kind of a concern. Of course, people say it was the same in two arms. Yes, but it was there. A lot of, quite some patients with stage 1B and 2 that never made it to the surgeon. And so what about targeted therapy? Well, there we have, again, the optimal aim, the yellow box. I'm not convinced that targeted therapy really kills minimal residual disease. It's a blocker of a protein pathway that blocks until the tumor control is lost and the tumor escapes. So it may delay, it may substantially delay minimal residual disease. I'm not so sure if it really kills minimal residual disease. And if you look, the same parallel as I made for immunotherapy, if you look at curves from targeted therapy trials, and you see one over here, chemotherapy versus gefitinib, you see that the curves go down. There's little plateau, there's no difference in overall survival. So I'm less convinced here, based on all what we have, that this will ultimately lead to a better 5-year overall survival and improved cure rate. But we need to see in the future. We have this trial, and it's in EGFR mutated, completely resected non-small cell lung cancer. Adjuvant chemotherapy could be given as indicated, and the patients had 3 years of a drug that blocks EGFR, osimertinib, or placebo. The primary endpoint was disease-free survival in stage 2 and 3A. And it's an early report because the trial was unblinded after interim analysis of the data monitoring committee. But all patients had at least 1 year follow-up. And it was unblinded because the difference was so major. But the data maturity was only 33%. That happens when you unblind in the course of a trial. But the hazard ratio for disease-free survival was 0.17, highly significant. What about tolerability? Well, that was rather good, as we can expect from osimertinib. There were grade 3 adverse events in 10% of the patients, no grade 4, no fatal adverse events, and only 3% of the patients with a serious adverse event. So where does this bring us? Well, these were the data. And from the data, you need to think about clinical relevance. And that's, of course, always also a piece of interpretation. So this is walking on thin ice, but I will give you my opinion. It's wintertime, so we can walk on thin ice. But here you have evidence mixed with opinion. You need to take that into account. What I felt was the most important in IMpower 010 was the analysis of the subgroups, where we saw the difference between a PD-L1 1 to 49 and a PD-L1 above 50, and the tolerability profile, the safety profile, with some major events in a minority of patients, but they were there. So looking at my yellow box again, in IMpower 010, in PD-L1 positive stage 2-3A, the disease-free survival hazard ratio was 0.66 with a reasonable follow-up time. And so FDA approved that therapy in that indication, and EMA might probably do the same. For me, it's likely that this disease-free survival benefit will be translated in increased cure rates. And I make the parallel with Pacific there in the next slide. Looking at the risk-benefit balance, we need to take into account that the hazard ratio in PD-L1 intermediate is not significant, in PD-L1 high is highly significant, and that there are a certain proportion of adverse events in patients. This needs to be continued now with more trials, placebo-controlled trials, which are even a better level of evidence. We need to look for predictive biomarkers in the future. I said parallel to the Pacific. Well, in the Pacific, it was first reported on the right side of the slide that there was an improvement in disease-free survival until now. We have data up to 5 years from that trial. And what we see at 5 years is that the difference in progression-free survival that was initially reported is maintained at 5 years. And that difference in disease-free survival also gives a difference in overall survival that is maintained at 5 years. So stage 3, unresectable treated with chemoimmunotherapy and durvalumab leads to a 43% overall survival at 5 years. What about the neoadjuvant approach? Well, we have this early analysis of CheckMate 816. So what we have in terms of evidence is still limited. It's an intermediate endpoint. It's clearly positive. And I made my concern about the 15% of patients never going to the thoracic surgeon. Again, putting this in the perspective of my yellow box, if you look at the phase 2 Swiss data, the 1-year event-free survival was clearly better. So they had a positive trial. It's likely for me that this disease-free survival benefit will be translated in increased cure rates for some of their patients. Again, thinking about the Pacific. In terms of risk-benefit balance, I think it's very reasonable to have an 82% resection rate in stage 3A and 2 patients, and that made it to surgery. CheckMate 186 is a very early report with a promising finding in the surrogate endpoint of pathological complete response. But I said 15% of the stage 1B2 patients never made it to surgery. So we need more mature time-dependent outcomes here. We need placebo-controlled trials, and we need to search for biomarkers. And then finally, EGFR targeted therapy. Again, looking at my yellow box, impressive disease-free survival hazard ratio of 0.17. And this has been approved in Europe by EMA in this setting. For me, but I can't be certain about the future, but I'm not convinced that this will lead to increased cure rates. And there are 2 previous trials with gefitinib, which is a less strong TKI, where the DFS benefit was not translated into overall survival benefit. In terms of risk-benefit balance, I think the DFS benefit is so major that even in the absence of an overall survival benefit, it justifies the indication, especially as there is a delay of brain metastasis as well in these patients with adenocarcinoma, and it's a quite safe therapy. Again, we need more trials, placebo-controlled trials in other settings, and predictive biomarkers. So this was my last slide, and we come back to the questions now to have the vote. But I see I made an indication about the correct answer. So we will not have the voting. It will perhaps be good for the timing as well. So about chemotherapy, it's clearly that this is a standard because it's better disease-free survival, better overall survival, but it may have dangerous side effects. Actually, with adjuvant chemotherapy, we see very little fatalities. Of course, it's different to tolerate for the patients from time to time, but with the treatment guidelines and dose reductions that we lose very little patients due to adjuvant chemotherapy. Neoadjuvant or adjuvant immunotherapy were clearly better disease-free survival. Overall survival uncertain, but personally I am quite hopeful there. And I try to show you that even if it's in general regarded as a gentle therapy, it may have dangerous side effects. And then targeted therapy, well, it's better disease-free survival, overall survival uncertain. And I'm not so convinced that it will be the case, but it's well tolerated. And the DFS benefit seen in the clinical trials is really a piece of evidence to say that this therapy is worthwhile for a patient. So by this, I think this was my last slide, and I will be happy to return to you with a discussion together with Lieven in the next few minutes.
Okay, thank you very much. Thank you for this very clear presentation, as it always is. I don't know if there's any questions from the floor. You can ask your questions in the questions bar. There was a question from on the checkmate 816. Why didn't the patients get surgery? Is there any more information on this 15% of patients that did not go to surgery? Could you comment on this?
Well, some patients did not go to surgery because the evolution of the tumor was not well, because there was progression during the preoperative period. Of course, you can say these are probably the more aggressive tumors, but still 15% is a lot when we compare this with chemotherapy-only trials. So for me, it remains a bit of a concern. It's not necessarily a concern about adding immunotherapy to chemotherapy, but it's a concern about how this trial in general was managed. Because, I mean, 15% of the reality is 15% of the patients did not make it to surgery. Well, if they had surgery first and then immunotherapy, they would have had their surgery. So it's difficult to compare this. I mean, this is extrapolation, but in general, the lack of surgery was not due to side effects that were more present in chemoimmunotherapy than they were present with chemotherapy, because they were rather well balanced. But so it was not going to the surgeon in about 15 to 18% of the really early stage patients in that trial. And I think in future trials, this should be better in order to advocate the neoadjuvant strategy.
Okay. Then the next question: how long do you recommend your patients to take immunotherapy or targeted therapy? It's
that's a very interesting, very difficult question. Our patients, is very simple. We follow what has been done in the clinical trials. And in clinical trials for adjuvant immunotherapy, if we will give it, because it's not labeled yet and it's certainly not reimbursed yet, but if we will give it, we will stick to the duration of 1 year. For targeted therapies, osimertinib was 3 years, so we will try to stick to the duration of 3 years if it becomes reimbursed. So we look to the clinical trials. Another question is, do the clinical trials really know the optimal duration? No, they don't. It's making a choice, and the choice that has been made for immunotherapy is 1 year. And we really don't know if perhaps for some patients 6 months may be enough, for other patients 2 years might be better. We don't know that. We have the evidence of the clinical trials as they are, and we try to follow that sequence.
Okay. And then the question on combining immunotherapy and chemotherapy: what's the rationale of combining them? Can your tutor cells develop resistance in immunotherapy?
Sorry, can you repeat the last sentence?
So can some cells develop resistance in towards immunotherapy or during immunotherapy? And is that the reason for combining immunotherapy and chemotherapy? Because in one of the trials, I think we saw that the immunotherapy only, this arm was dropped very early.
Yes. Well, there is a first historical reason for this. In this setting, whether you give it adjuvant or neoadjuvant, chemotherapy is a proven value, as I showed, within stage 2 and 3, a difference in 5 years of 12 and 15%. So omitting this and giving immunotherapy only is quite risky, in my view. That's the first thing. The second thing is, in immunotherapy induction only trials, the degree of pathological response and major pathological response was clearly lower. So that's the second thing. And the third thing is, there is a kind of additive effect, of perhaps even a synergistic effect between chemotherapy and immunotherapy, in the terms that chemotherapy may destroy tumor cells that make a kind of priming for immunotherapy. So I think the future is in giving chemo and immunotherapy together, not in immunotherapy alone in the induction setting.
Okay, and then the question that follows on that, will chemotherapy, plus dual immunotherapy play a role in the future?
I don't know that. Of course, there will be clinical trials looking at that. What we know from metastatic disease of chemotherapy plus dual immunotherapy is that the side effects become quite important, with quite some patients needing to stop the therapy because of toxicity.
Mm-hmm.
So in this setting, in some phase 2 trials, of course, and it has been done already in some phase 2 trials, there is clearly increased toxicity, and the balance between benefit versus danger will need to be very carefully observed. I think at the present time, in this setting, the evidence says to me that combining chemotherapy plus single agent immunotherapy is at the present time the way forward.
Okay. And then neoadjuvant or adjuvant, because I saw that you already had some question marks on the neoadjuvant with 15% patients
Yes.
not being able to be resected. So your preference would be adjuvant or neoadjuvant?
At the present time, taking into account the duration of the follow-up of the trials, the certainty of the results, because we need to realize that the Checkmate 186 was not placebo-controlled, so there can always be some hidden imbalances of people doing things differently in one arm versus the other arm. I think the global evidence that we have now is in favor of adjuvant immunotherapy, and that will be the first registration. It is the first registration with FDA, and probably will be the first registration with EMA as well. I think we need a little bit more time before we go to the neoadjuvant scene outside of a clinical trial, even if I showed you the preclinical models. In terms of scientific evidence, it looks very attractive, but it's also very attractive if the patient has a surgery. So I think at the present time, I would favor the adjuvant setting.
Okay. Then a question on EGFR and PD-L1 together. Is it a common finding that you have EGFR mutation and a high PD-L1 status? And how do you select them for adjuvant therapy?
No, in general, patients with EGFR mutation have a rather low PD-L1 value, although there are exceptions. But even if they have a better PD-L1 value, EGFR tumors have a completely different immunological microenvironment. And we know that from metastatic disease, EGFR mutated tumors respond very poorly to immunotherapy, and it has little role in the treatment actually. So in the clinical trials, in the adjuvant clinical trials, because the knowledge was not there yet, these patients were not always excluded. In modern trials, they are excluded. But the choice for clinical practice, if you have an EGFR mutation, is clearly in the direction. If you have an EGFR mutation, the proven benefit of adjuvant chemotherapy remains very important. But in terms of adding new agents, there you go to the targeted therapies with little role for immunotherapy.
Okay. Next question is if you expect to have in the future more extensive resections, because with adjuvant or neoadjuvant immunotherapy, we could go further in our surgical indications, maybe?
Well, this has been said when the induction chemotherapy started as well. I think even with these new agents, it remains very important that at the initial multidisciplinary tumor board, there is a good discussion with the thoracic surgeon about the feasibility of a complete resection baseline, but even after induction. So increasing the chances for complete resection may be the case predominantly if the T factor is the problem. And there we know from trials, but then mainly trials with chemoradiotherapy induction, that it may increase resectability and lead to rewarding results. I think the induction therapies do not really have the aim of making patients with non-resectable disease resectable. The upfront discussion with thoracic surgeon at the multidisciplinary tumor board is very important. At least this is how we see this. And then the patient is directed either to a surgical combined modality treatment, where fortunately the immunotherapy will come in soon now as well, because it's not there yet. Or he will go to a non-surgical combined modality therapy, chemotherapy plus radiotherapy plus immunotherapy, the Pacific regimen. And I've shown the results there that are quite good. That is, you see what happens at 5 years. So I think these are two really different settings that need to be discussed in depth in an interdisciplinary way at the baseline multidisciplinary tumor board. I don't think that the systemic therapies are made essentially to make shifts in categories.
Okay. Another comment on the adjuvant immunotherapy. The curves are separating after 3 to 6 months, and then they go parallel most of the time. So the comment was again, why do we give it for 1 year then instead of just for some months? But as you said, that's because of you follow the trials.
It's a choice that has been made in metastatic trials. It's in general 2 years. In non-metastatic trials, it's in general 1 year. But that is a choice in equilibrium between potential for improvement, potential for side effects, and burden to the patient. But we follow the clinical trials as they have been done, and it is not very likely that very soon we will have a better answer on duration than we have anno 2022.
Okay. And coming back on the previous question on the extending indications, on the other hand, would you expect after or in the era of immunotherapy, would you expect less work for thoracic surgeons or not?
As we work in our multidisciplinary tumor board, I would expect not, because we have the upfront decision of surgical versus non-surgical combined modality treatment. And in both settings, we will probably substantially improve the outcome for patients. It has already been shown for stage 3 unresectable with chemoradiotherapy followed by immunotherapy. And now gradually the data are dropping in for the surgical combined modality therapy, where we also see improvements in outcome with, as I try to suggest, probably increased cure rates. So they are different settings that need discussion at the multidisciplinary tumor board at baseline. And there the group needs to make a good choice. And then systemic therapies try to improve in both settings, try to improve outcome. Systemic therapy does not necessarily tries to make a shift between these two categories.
That's clear. A very specific question. Is there a place for adjuvant osimertinib in EGFR mutated patients in exon 20?
Not at all, because EGFR exon 20 is notoriously resistant to the current TKIs we have in the metastatic setting. So not at all. And well, unless of course you're talking about a specific mutation T790M that is within the target of osimertinib, but the typical exon 20 mutations are insertion mutations, and there our standard TKIs do not work at all in the metastatic setting. So we don't need to get them in the surgical setting. There are specific agents in development for exon 20 mutations in the metastatic setting, but we are not there yet in terms of full results in the metastatic setting. So it's still quite a way to go, I think, before we go to the surgical setting there.
Okay. Any news on mRNA vaccines for lung cancer? Any research in the field?
There is certainly research in the field. So what we have learned from the past is that vaccines only, as they were developed previously, as in the big adjuvant vaccine study that we did not make a difference in disease-free or overall survival. And that's probably because they generated not enough cytotoxic tumor killing cells, CD8 cells, and because they were not strong enough to reverse the immunosuppressive environment in lung cancer. And so nowadays, the development of vaccines is more in combination with checkpoint inhibitors. And there are a lot of interesting things ongoing, especially the combinations of checkpoint inhibitors with vaccines that do induce CD8 cytotoxic cells. And there are such vaccines ongoing. They're not necessarily of the mRNA type. There's a lot of type of vaccines, but it's an interesting early development. But I would not say that based on the historical trials that were disappointed, that the vaccines are ruled out of the business now.
Okay. Then a question that typically comes back in every surgical discussion. People that are for surgical treatment first or for neoadjuvant chemotherapy and then surgery in 3A in 2 disease with only single level station disease. What is your opinion on in 2 disease with only 1 station affected?
Well, that is not necessarily related to the issue of systemic therapies. That is more related to an issue of global baseline assessment of the patient. And I think there are, yes, there's really a kind of divergence there, and there's my personal preference is in the case of N2 disease to go for a neoadjuvant approach with chemotherapy and maybe chemoimmunotherapy in the future. Let's look at the Swiss experience, for instance. If it's well done in a good surgical group like the SAC group, then you see that most of the patients can get to resection even in higher stages. But the reason why I say this is that the main pattern of failure after surgery for N2 disease is systemic. So the earlier you enter the systemic disease in the therapy, the better in that setting. And this is why I have a preference for the neoadjuvant approach there, because we know from the chemotherapy trials that very little patients do not make it to the surgeon, less than in the trial that I showed. And the chemotherapy is better tolerated in general. So my personal preference is to give neoadjuvant chemotherapy, but I know there is a lot of discussion, and there are groups that prefer to have an upfront surgery with mediastinal lymph node dissection and then have the chemotherapy in an adjuvant way. I think there's no real black and white here. What we know from the meta-analysis from the past is that the outcome of chemotherapy plus surgery was more or less the same in meta-analysis if you give it preoperatively or postoperatively.
Okay. And then I see that Professor Schmidt-Opitz wants to come back on the resectability discussion after induction. So you already said you in the tumor board you discuss everything on beforehand and you stay to the plan. You stick to the plan also after induction. Would there be anything the question is, so what do you think about moving the resectability discussion to after induction?
I don't think that is a very good idea, because if you move the resectability discussion until after the discussion, it means you lose the upfront choice in appropriate patients of radical chemoradiotherapy followed by immunotherapy. Because if you give the induction and then you assess, and then you come to the conclusion of the resectability is very doubtful, then you lose the opportunity to give a good concurrent chemoradiotherapy, which, as we have seen, concurrent chemoradiotherapy followed by durvalumab, 5-year survival more than 40%. So I don't think there are many surgical trials that beat that. That's the first thing. And second, you lose the opportunity if you have an interim analysis and you lose some time. You can never give a full course of radiotherapy without interruption if you do this. And for that reason, at least in our multidisciplinary tumor board, we don't prefer this type of strategy.
Okay, and maybe one final question. So in the studies with neoadjuvant therapy, was there so immuno and chemotherapy, was there a difference between the planned surgical resection and the actual surgical resection? You can imagine that the patient was planned for pneumonectomy, for instance, and then got a sleeve, or going for a sleeve and just having a simple lobectomy. Do you have any comments on that or data?
I don't have that at the tip of my fingers. I don't think there was such a big shift between the type of planned resection, but I'm not totally sure. I need to go back to the data to be more sure about this.
Okay, I thank you very much. It's 7 o'clock. Today was, for me, as at least a great ESTS webinar with more than 200 live attendees and many interactions, as you have seen. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Vansteenkiste, for this excellent webinar today, and you, of course, the audience, for your interest and your interaction. We hope to see you again next month for the webinar on robotic lung resections with Jean-Marc Bast from Rouen, France. Thank you again, and hope to see you next month.
Thank you. Bye-bye, everyone.
Bye.